Greetings, folks. It's Beth Wright providing you a podcast for NUR 236, Unit 2, which is all about the immune system. And in this podcast, we're going to talk about both Chapter 9 and 11. So Chapter 9 talks about drugs that enhance the immune system, and we're going to cover the interferons here. So when you look at interferons, you got to think about how they help that immune system. Excuse me. And we're looking at interferons as biological response modifiers. And when you think about the word interferons, think about the word interfere. It interferes with some things that happen in the immune system in order to enhance. And we're talking about viral infections here, so that's, where it interferes. So if you remember way back in Chapter 1 of pharmacology, which would have been Pharm 136, you had a definition of a word, biotechnology. And this is what we're talking about when we're speaking about biological response modifiers. They have learned about biotechnology where it involves using the RNA and the DNA and recombining genes into hybrid molecules that can help enhance the immune system. And so that's what we're talking about here with the biological response modifiers. So they bind to specific cell surface receptors and they alter intracellular activities. They are defined as intrinsic and extrinsic substances. Intrinsic meaning within the body, extrinsic outside of the body. Substances that enhance the body's response to infections. So with viruses, interferons induce enzymes that help viruses and stop the growth of viruses, basically. They provide anti-proliferative activities. They increase histocompatibility complexes, which is again a part of that immune process. They augment the natural killer cells of the immune system, and they assist the cytotoxic T cells, and they inhibit angiogenesis. So they, have found to be very beneficial. So the action of the interferon medication is going to be that the drug is an antiviral as well as a neoplastic cancer drug because it stimulates the immune system by halting the reproduction of a virus, and it increases that phagocytic activity of the macrophages and monocytes, which is part of that natural killer cytotoxic cells going to work against cancer cells. So interferon alpha 2B is our main medication here, the prototype medication. And again, it's a recombinant DNA technology that actually uses E. coli. Isn't that cool? So when we see that word recombinant, when we're talking about genetics, that means it's the process of creating new combinations of genes by shuffling the linear order of DNA. And so the use of this drug has to be with 18 years or older. And we see that with clients with hairy cell leukemia, chronic hepatitis B and C, Kaposi sarcoma, which is a common thing you see with HIV patients, malignant melanoma, which is a type of cancer, and the condylomata, What that is a raised growth on the skin that resembles a wart, typically in the genital region, and it's caused by viral infections or syphilis, and it's transmissible by sexual contact. Now, with special populations, neonates and infants, which the age of that, the neonates is full term to 4 weeks, and then infants is 4 weeks to 1 year. It should not be used with them because it contains the benzyl alcohol as a part of its makeup, and that can cause neurological disorders. This medication is contraindicated in liver impaired patients, so we got to look for, any kinds of signs of liver impairment, ascites, bleeding disorders, jaundice, decreased albumin. Also looking at their lab work for their liver panel, and also autoimmune diseases and post-transplant clients. We don't want to use it in that. Our adverse effects with this medication can be flu-like symptoms within 2 hours up to 24 hours of taking the medication. They can experience chest pain, alopecia, which is hair loss, dyspnea, shortness of breath, visual problems, light sensitivity, neutropenia, anemia, thrombocytopenia, and psych issues such as depression, psychosis, and suicidal. So the drugs should be stopped if that happens. So when we're looking at our nursing process for this particular medication, we definitely, got to assess for, any of those contraindications, allergies, make sure we got the right patient ID, make sure we have an indication for the medication. For our nursing interventions, we are going to, of course, administer the medication properly. It can be given sub-Q, IM, or interlesionally 3 times a week, at least 48 hours apart. We're always going to include that teaching, and in your text, the box 9.1 is going to go over that. We want to teach about how to administer, how to store it, hygiene, teaching, keeping regular appointments, watching for adverse effects, and of course when they experience anything adverse, when to call the doctor. Drug-drug interactions also are something that we have to be watching about, and those are listed in box 9.2. And of course our evaluation is going to be checking about therapeutic effects. What is the med being used for? If it's 18 years old and older with hairy cell leukemia, is the leukemia showing improvements? We'd look at the lab work on that. If it's for chronic hepatitis B and C, what are our signs of improvement there? Is the jaundice improved? Is the lab work improved? Energy improved? Kaposi sarcoma, are lesions decreasing? For malignant melanoma, are signs and symptoms improving? For the condylomata, are the lesions decreasing? For adverse effects evaluation, we want to, check about the flu-like symptoms, check about chest pain. Are they having any hair loss? Are they having any trouble breathing? Any visual problems? Anything problems with their white blood cell count due to the neutropenia? Anything with their red blood count due to the anemia? And platelet count due to thrombocytopenia, and of course those psych issues. Are they having any problems there? Okay, Chapter 11, we're talking about drugs that suppress the immune system. And of course, the immunosuppressants interfere with production or function of the immune cells and the cytokines. And the cytokines, I like to call them our cousins of the immune system because they're there to help when we get into trouble. Cousins are good. If you have good cousins, that is. And they act as messengers between cells, and they help regulate that inflammatory response. So the purpose is to stop that immune system from attacking and hurting itself or a transplanted organ. Okay. The use of these agents, of course, puts the patient at risk for infection because we are suppressing the immune system. We safely use immunosuppressants by monitoring the patients routinely with lab work such as a CBC, BUN and creatinine, GFR for kidney function, and our liver function due to issues that can develop with the liver. Any signs of illness or fever, infection, the patient should be seen by the healthcare provider immediately. And our cytotoxic immunosuppressant agents that are listed as your exemplars are your mycophenolate, methotrexate, and then your conventional anti-rejection agents are your cyclosporin and your corticosteroids. So again, the immune response is designed to protect the body from disease, and the role of the immune system is to protect the body against agents which will cause injury, harm, or disease. And when the immune system is injured or suppressed, we have to expect diseases to occur. However, there are times when we want to suppress the system so that it doesn't destroy foreign agents in the body. And an example of a foreign agent in the body would be an organ transplant. So we want immunosuppressant. It's necessary with organ transplant. And this is a lifelong treatment for patients who are organ transplants. Because we don't want the body to attack and destroy the transplanted organ. Or you could have, in the case of autoimmune disorders, where the body's attacking itself. We want to shut that immune system off. Cytotoxic immunosuppressant agents damage or kill dividing cells. It's used as chemotherapy with cancer, but in lower doses it's used for autoimmune or preventing organ rejection. Conventional anti-rejection medications, the drugs are fungal metabolites with strong immunosuppressive effects, which is kind of cool to think about. Suppresses the helper T cells and expression of cytokines and immune response involved in organ rejection. Corticosteroids are also in this chapter listed, although as far as use them for suppressing the immune system, and you know that corticosteroids does suppress the immune system, but we don't see that used as much for organ rejection as we do for other things. So we'll spend time on a different podcast with corticosteroids. Okay, adjuvant medicines used as immunosuppressants. We have the monoclonal antibodies, and take a look at the name of that, monoclonal antibodies. So you know antibodies are a part of that immune system. They're also known as immunoglobulins in the immune system. Our medication, or your exemplar for that, is omalizumab. Notice that a lot of these words have that mab at the end of them too. So think about the immune system when you see that mab at the end of the generic medication name. So the antibodies, monoclonal antibodies, or are a part of that immune system, and they are substances produced by the immune system in response to foreign invaders such as bacteria or viruses. Antibodies can stick to the invader and help destroy it. Now, monoclonal antibodies are specific types of antibodies, and it's created in a lab to find and destroy a particular target. So these are therapeutically replicated in a lab to react to specific antigens to alter that immune response to the antigen. In your text, it explains how these meds are produced, literally in the lab using mice and hamsters. Your tumor necrosing factor medications, alpha blocking agents, we have 3 listed there. Infliximab, adalimumab, and etanercept. Okay, so 2 of them have the mab at the end of them, and etanercept, just thinking about cells there with sept. But let's talk about what tumor necrosing factor is. One of multiple proteins capable of inducing necrosis of tumor cells that possesses a wide range of pro-inflammatory actions is what tumor necrosing factor is. It is a multifunctional cytokine, basically, and you'll see the abbreviations TNF for this. So drugs that block the action of TNF have been shown to be beneficial in reducing the inflammation in the inflammatory diseases. These drugs are also known as cytokine inhibitors. And then we have our fusion protein inhibitors, the beta-sept. Fusion protein inhibitors are synthesized from an IgG antibody fused to a cell protein that binds to antigen molecules, and this prevents activation of the T lymphocytes and production of inflammatory cytokines. So immunosuppressants are typically used in combination to maximize effectiveness and minimize danger associated with organ rejection or autoimmune disorders. So, of course, consequences of immunosuppression is making a patient immunocompromised, and blocking that immune system will definitely do that. It is most helpful in organ transplants, but it does increase the risk of infection. So we need to teach the patient about avoiding anyone with colds, fever, flu, signs of infection, or tuberculosis, avoiding foods that are undercooked, such as raw fish or sushi, avoiding large crowds, the whole gamut of that immunocompromised teaching that we need to do with patients that are having a suppressed immune system. So risk factors associated with immunosuppressants are going to be infection. Also cancer, especially lymphoma, can develop because of using these drugs. Hypertension is an issue. Renal problems are an issue, so we got to monitor the patient. with that, hepatic disease, high cholesterol, and of course with corticosteroids, you need to watch for hyperglycemia, fluid retention, suppressed immune system with a low leukocyte count. Moon phase and edema can also occur with that. So key concepts are found on page 195, and it helps give you useful information regarding these drugs. That concludes your podcast.